Uterine fibroids, also called leiomyomas, are benign tumors that develop from the uterine muscle. They represent the most common pathology in women of reproductive age. Regarding the diagnosis of uterine fibroids, in 50 to 80% of cases, fibroids are discovered incidentally during a gynecological examination or an ultrasound, as they are often asymptomatic. However, when they cause symptoms, several signs may appear. Menstrual disorders are common, such as menorrhagia, heavy menstrual bleeding caused by the shedding of a hyperplastic endometrium, metrorrhagia, uterine bleeding outside of menstruation, or menometrorrhagia, a combination of heavy and irregular bleeding. These disorders can lead to anemia. Uterine fibroids can also cause urinary problems, including pollakiuria, frequent need to urinate, and urinary incontinence. Other symptoms include a sensation of pelvic heaviness, pain, as well as a progressive, painless increase in abdominal volume. Occasionally, abnormal discharges such as hydrorrhea, watery discharge, or leukorrhea, abnormal vaginal discharge, may occur. Uterine fibroids can be associated with infertility or obstetric complications such as miscarriages, abnormal fetal presentation, or complications during delivery. Clinical examination begins with a general assessment to detect any systemic abnormalities. Next, a gynecological examination is performed, including a vaginal examination and abdominal palpation, ensuring the bladder and rectum are empty. During this examination, the fibroid may present as a regular mass with firm, non-elastic, painless consistency, sometimes smooth or nodular with variable size. It is important to note that the tumor is generally attached to the uterus, meaning that movements of the tumor are transmitted to the cervix and vice versa. In some situations, the uterine volume may be normal, particularly in the case of submucosal fibroids, which are located beneath the uterine lining. Pelvic ultrasound is the first-line examination and is considered the gold standard. It allows confirmation of the diagnosis by identifying a solid, hypoechoic, homogeneous tumor with regular contours, an increased uterine volume, and deformation of its contours. It can also show a deviation of the uterine cavity line and vascularization, generally peripheral. This examination allows determination of the number, location, and size of fibroids, providing a complete mapping of the arrangement. It can also detect endometrial hypertrophy and assess the adnexa. Hysteroscopy allows the diagnosis of endocavitary and submucosal fibroids. It is also useful for performing resection of a submucosal myoma and a biopsy in the presence of suspicious findings or postmenopausal metrorrhagia to rule out endometrial cancer. MRI is performed if the diagnosis remains uncertain after ultrasound. It is indicated in cases of more than 5 myomas, large fibroids, subserosal remodeling, or suspicion of uterine sarcoma or uterine endometrioma. Biological workup includes a complete blood count, CBC, ferritin, blood group, as well as testing for anti-Rh antibodies and anti-nuclear antibodies to investigate secondary anemia and assess the possibility of transfusion.